Good afternoon, everyone. Welcome to today's session. I'm Dr. Aravinda Lochani, consultant neonatologist at KIMS Cuddles, Kondapur. Today, we will discuss about amplitude integrated EEG in neonates and its usage in NICU in different settings. So the objectives of today's presentation will be to know the utility of the CFM and aEEG machines and discuss their indications in clinical practice and to know the differences between the conventional EEG and amplitude integrated EEG and to see the different connections of aEEG machine and monitoring also we will discuss briefly when the baby is on aEEG. We'll also see the different patterns that appear on the aEEG, the normal pattern and how to differentiate it from the abnormal pattern. And in addition to this, we will see how to detect the impaired cerebral function in different conditions like perinatal asphyxia, hypoglycemia, different causes of neonatal encephalopathy. Such as bilirubin encephalopathy, inborn errors of metabolism, and how to identify a seizure and differentiate it from artifact based on the aEEG and comparing it with simultaneously with the conventional EEG. And what is the effect of medications on the EEG graphs? And the maturation of the EEG patterns according to the gestational age, and also the prediction of neurological outcome and the prognostication of the baby's future based upon the normalization of the EEG following the treatment, and also the different caveats, that is the limitations of aEEG and when we should opt for the conventional EEG. So if you see we are using different multipara monitors to monitor the baby's other vitals like pulse rate, heart rate, blood pressure, invasive blood pressure. So all these we are monitoring for the babies on a day-to-day basis, but EEGs are not being that regularly used equipment in the NICUs, mainly because of sometimes they are involve the usage of the invasive electrodes. With the non-invasive electrodes, the hydrogel and all the impedance and all we should observe, and the contact period should be properly maintained, and the artifact should be noted down properly to differentiate it from the seizure, as well as between the any abnormal movements in the aEEG related to the artifacts like the baby movement or administering a medication, nebulization, suction. And continuous EEG monitoring is required in cases of seizures which come intermittently. So to identify the seizures at any particular point of time. So continuous EEG is always beneficial when compared to the intermittent EEG. So that is the limitation of the EEG and the interpretation of the same. So like how to interpret whether this is related to artifact or whether it is related to seizure is one learning point that everyone should practice and keep on doing it in the NICU so that the utility of the EEG in diagnosing the seizures can be maintained. So now let us briefly delve into the history of the EEG. The original cerebral function monitor was designed in the late 1950s in the adults. Then it was subsequently adapted for neonates by Linda DeVries and Hellstrom Westers. And from then on, the cerebral function monitoring is being done for the babies. So the aEEG is used for continuous monitoring of the cerebral electrical activity critically in newborns. So that is one differentiating feature from the standard EEG, which cannot be continuously placed for the babies. The machines are bulky. Compared to that, aEEG machines are handy and they can be placed bedside in the NICU and it can be continuously monitored for the babies. These are initially used for the assessment of babies who are born after perinatal asphyxia or after any seizure activity, encephalopathy, to detect the cerebral function and to note down the frequency of the seizures and their response to the medications. In fact, the administering the anti-seizure medications after the confirmation with the electroencephalogram is only ideal rather than using only the clinical basis of treating the seizures. So when compared to the conventional EEG, the amplitude integrated EEG involves either a single channel in which biparatal leads are placed or a dual channel in which two pairs of leads will be placed in the frontoparatal areas. So the EEG, in the EEG, the the activity whichever is detected by the conventional EEG, it goes through a layer of processing, so that it is first amplified and then filtered and rectified, and then the signal will be shared on the screen, so that the 6 centimeters of the aEEG represents the 1 hour of the graph on the conventional EEG machine. And it also to remove the artifacts, any activity which is detected less than 2 hertz and more than 15 hertz is attenuated, and it is filtered when it passes through the amplitude integrated EEG machine. This information is provided on the background, and it is useful for determining the effect of encephalopathy, effect of drugs, and the prognostic value, as we already discussed. So now let us see what are the advantages of the EEG machine. In short, like how is it different from the conventional EEG? This amplitude integrated EEG is a handy machine, and it is simple and easy to learn. It's also cost effective and reliable, and we can get direct information about the baby's neurological function and cerebral activity, and it is non-invasive. If we don't use the needle electrodes, we apply the hydrogels, then it becomes non-invasive and easy to use, and it has a wide range of applicability in all the CNS conditions. So it helps to continuously monitor the functional state of the brain over hours to many days as well. So now let us see the indications of using aEEG. So this we should have some specific set of indications where we decide to use the amplitude integrated EEG, not in every newborn. So the most common indication being hypoxic ischemic encephalopathy or any neonatal seizures or clinical scenarios mimicking the seizure disorders, like babies having some clinical conditions like apnea, hypertension, and tachycardia suggestive of seizures, and any significant neurological disorders when we suspect congenital brain malformations or vascular lesions. Post cardiac arrest, hypoxia can lead to the seizures. In those conditions also, we can monitor with aEEG. And when we have a baby where we suspect the inborn errors of metabolism, like urea cycle disorders, amino acid based disorders, or metabolic abnormalities like hypoglycemia, hypocalcemia, then also we can monitor with the aEEG. And in the case of some maternal intoxications, and to detect the withdrawal symptoms in the babies like alcohol and opiate withdrawal, also we can monitor the baby using the amplitude integrated EEG. And there are certain other applications for EEG, such as to delineate the effects of anti-seizure medications, like when we give the phenobarbital or midazolam, we can observe the pattern of the EEG, how it will affect the amplitude and the frequency. And to evaluate the appearance of the sleep-wake cycles, which is one of the important prognostic marker for asphyxiated infants. Early return of sleep-wake cycles determines the good prognosis for the baby, and to predict the post-neonatal epilepsy in asphyxiated infants. And there are certain changes in premature infants, like beginning with the 21 to 22 weeks, the completely maturational pattern of EEG in babies is seen around 35 weeks of gestation. To define the maturational changes in the preterm babies also, we use EEG. And to predict the outcome of infants with large IVH, we can use the EEG. So these are some of the common differences between conventional EEG and amplitude integrated EEG. The first one is the number of electrodes. When compared to conventional EEG, where we use a lot of electrodes on the baby, around 12 electrodes, for aEEG, it is minimal, around 2 or 4 electrodes can be used, as we discussed. And conventional EEG needs a lot of expertise, like we need an EEG technician or a neurophysiologist for placing the leads and for continuously monitoring the readings on the computer. Whereas aEEG can be done easily on the bedside with few techniques which need to be learned. And it can be kept for a long time. It can be used for bedside monitoring also. Continuous monitoring might be difficult with conventional EEG. But the advantage with conventional EEG is it can detect the seizures, short-lasting seizures, which can occur, that sometimes we get missed with amplitude integrated EEG because of the time compression which we do in aEEG. And conventional EEG can also detect the focal abnormalities which might get missed with aEEG. And whatever said and done, even if we do the aEEG, it's always better to confirm the seizure with the conventional EEG, because it covers a lot of surface area of the brain, because some areas might get missed with the amplitude integrated EEG, because we will be applying only to the specific areas of the brain. So these are the different EEG monitors which we use in the routine practice. The common examples are the Olympus and the brains monitors which we use. They will have a monitor where the EEG graph will be displayed, and they also provide with a remote control where we have to insert the leads and connect it to the specific areas as displayed on the monitor on the baby's scalp. And then we have to switch on the EEG, which will start recording the graph on the EEG. Simultaneously, we have to be checking for the impedance. That is the resistance, which should be kept at a minimum. So how to place an EEG and record it for the babies, that we will see now. So it is recorded like as we have earlier discussed with two channels between two parietal electrodes. Always the odd number, like suppose F3, P3 means it's detects the left side of the brain for the baby, and even numbers F4, P4 they detect the right side of the brain. So frontoparietal electrodes can be placed if we are using the four electrode method, and a neutral electrode will be placed in the midline of the scalp of the baby. So the EEG graph which is obtained will be amplified and then filtered above, and the graph will be attenuated below 2 Hz and above 15 Hz as we discussed, and then it is rectified, and smoothing will be done with a time constant of 0.5 seconds, and time compression will be done. So for 1 hour of conventional EEG, it will be recorded in 6 centimeters in the amplitude integrated EEG. The signal produced is enhanced and displayed in a semi-logarithmic scale. Why it is called semi-logarithmic, I will tell you. So from 0 to 10, the scale will be linear. From 10 to 100, the scale will be logarithmic, because I will show you in the EEG graph. So if you can see in this aEEG graph, so on the left hand corner, you can see some markings on the top: 0, 5, 10, 25, 50, and 100. So if the graph can be divided into two parts, the lower half is occupying only 0 to 10. And from 10 to 100, it is represented entirely on the upper half of the graph. So that is why it is called as a semi-logarithmic. From 0 to 10, the recordings will be in the linear scale. From 10 to 100, it will be in the logarithmic scale. Since both are available on this graph, it is called as the semi-logarithmic model in the amplitude integrated EEG. So that is the semi-logarithmic scale on EEG, and signals at the lower amplitude will be enhanced, and at the higher amplitude they will be attenuated. So this we discussed 6 centimeter per hour recording of the brain activity. So these are the methodology of the principle of EEG. The standard EEG, the filter will be applied below 2 Hz and above 13 Hz, and the graph will be obtained, and then the amplitude will be compressed on the semi-logarithmic function will be obtained, and it will be rectified, and time compression will also be done, and then the graph will be displayed on the aEEG. So here you can see on the topmost we have the conventional EEG, where it was recording for 1 hour, that is compressed to 6 seconds in the F, the lowermost graph, which is the display for the amplitude integrated EEG. So now we have all understood how the method of aEEG is there. Now we should see how to apply the same electrodes on the baby and how to start working on the EEG. So these are the signal pathways that were earlier used for the cerebral function monitor. So in this you can see here in the midline of the scalp, there we have the neutral electrode or the guard electrode, and on the sides, both the frontoparietal areas, we will keep the recording electrodes. The same will be displayed on the monitor of the EEG, the Olympus or the brains model of the EEG machine will have this 3-lead or 5-lead selection. So you can, if you are going to use the 5 electrode model, you can select it on the machine, and correspondingly the same electrode can be connected to the remote, and the patient data can be entered, and we can start recording the amplitude integrated EEG. So then there will be an impedance detector which will detect the resistance to the signal which is coming from the brain of the baby. And then the subsequent steps, as we discussed, like amplification, filtration, semi-logarithmic amplitude compression, and then rectification, smoothing, and recording of the cerebral activity. So if the impedance is higher, then it will display on the monitor that the impedance is going high. Then we should see like whether the electrodes are placed on the scalp correctly, whether the gel is being applied properly. There should not be any hair where we apply the scalp electrode. So all these things should be taken care, and it should not like be partially approximated to the skin of the baby. It should be completely approximated with no air gap in between. So to record the graphs properly. So these are the connections. So these are the electrodes which we place on the scalp of the baby, and this is the monitor. Here you can see that there are for 5 electrodes they have given on this side. There will be 5 connections to connect the electrodes there. So 5 channels will be there. Those the other end can be applied to the scalp by applying a hydroelectrogel. And then trace the recordings on the monitor. So these are the conventional EEG electrode placement. Here you can see on this picture. So when compared to this 12-lead conventional EEG, here we place fronto-parietal. So left side will be the odd numbers and right side will be even numbers for placing the electrodes in addition to the neutral electrodes. So total 5 electrodes will be placed and the recording can be started for dual channel EEG. So when you see roughly for a full-term newborn, it will be 3 centimeters posterior to the vertex, the posterior part, and the electrode placement in between these 2 electrodes, there should be at least 6 centimeters of distance. So it should not be too close so that the readings will get disturbed and misinterpreted. There should be sufficient space between these 2 electrodes, and it should be at an equidistance from the midpoint on either side of the scalp. So channels F3 and P3, F4, P4 are generally recommended. So you can see the same positions on the scalp of this baby, both on the right side as well as the left side. So now let's discuss about the impedance in the amplitude integrated EEG. Impedance is nothing other than the resistance to the current flow, which measures the quality of skin placement and the lead placement. So impedance should be ideally less than 10 kilovolts of amplitude, and it should be stable to ensure optimal EEG recording. So if the impedance is going up, then we should look for the placement of the electrodes, whether they have been placed properly or not, whether the gel has been applied properly or not, whether there has been any hair at the place of application that is not leading to effective seal between the electrode and the scalp of the baby. So there are other needle electrodes also which are placed in the subdermal position that may be invasive, but to avoid that we are using the hydrogel based electrodes. And then we should avoid the other sources of disturbance that may lead to the appearance of the artifacts, such as adjusting the ventilator frequency and avoiding too many interruptions at the time of recording of the EEG, like doing the suction, nebulization. And if any caregiving activity has been done, it is better to record that in the notes so that we can differentiate those artifacts from the original seizures. So these are the different types of machines: Olympic CFM 6000 and the Brains BRM monitor, which are currently used for recording the EEGs. So, and both of them display the impedance values on the screen. So if there is an acute and critical change in the cerebral perfusion or metabolism, it will affect the amplitude and continuity of the EEG signal. Gradual and moderate changes, they modify the frequency composition of the EEG. This is a very important point which we all need to remember. With the EEG technique, it is possible to record the cerebral activity for prolonged periods of time in both the full-term and preterm infants. So now let us see some of the patterns that we generally see and we should note down when we are seeing an EEG. So there are some like normal EEG patterns called a trace discontinua, which is discontinuous and is seen in the preterm infants. So this pattern generally becomes normal, and this discontinuity pattern will not be seen as the infant grows more than 35 weeks of gestation, which we will see in our further slides. And then, so this we should keep in mind based on the gestational age of the baby. Whenever we are commenting on the baby, we should first note down the gestational age, and then we should comment upon the background pattern, whether it is a continuous pattern, discontinuous pattern, we should note down first. Continuous pattern means the lower amplitude will be always above 5 and above 10 and most of the situations, and the maximum amplitudes will be between 10 to 25 microvolts. This pattern is always called as the continuous normal voltage. It is a common pattern in the full-term infants. Discontinuous pattern is of different types. Discontinuous activity with minimum variability of amplitude we should note, but mainly below the voltage will be below 5 microvolts and the maximum amplitudes will be up to 10 microvolts. When we call it as burst suppression, it will be a discontinuous activity with minimum amplitude without much variability, and bursts with amplitude more than 25 microvolts will be there. Without much variability, and there will be a lot of bursts and suppression. Burst and suppression will be there with minimal interburst intervals. Continuous low voltage pattern, when we say the amplitude is of very low and there are not many bursts, and the amplitude is always coming below 5 microvolts. Flat trace is mainly inactive background with the electrocerebral inactivity below 5 microvolts. We should say it as a flat trace. So the discontinuous, burst suppression, low voltage pattern and flat trace, these are all abnormal backgrounds, and continuous background is a normal background. So first, after noting down the gestational age, we should comment on the background pattern, and then we will see the sleep-wake pattern. Sleep-wake pattern is the cyclical alterations in the behavioral state that can be evaluated based on the differences in the baby's activity states, that is like eye movement, muscle tone, spontaneous muscle activity, and baby's breathing movements, which leads to the formation of a spindle-like wave pattern. That is a common pattern which is seen from 25 to 26 weeks of gestational age onwards. And the other pattern which we see on the EEG is the seizure pattern. So now let us see all these patterns one by one. This is the sleep-wake cycling. In this you can see there is the spindle-like somewhere. At some point it is becoming narrow and other point it is becoming broad. The EEG pattern is becoming broad and then it is becoming narrow and broad again. This is a normal pattern which is seen in the babies. So this sleep-wake pattern appears because the baby will be having the normal activities like eye opening, spontaneous muscle movement, respiration. So this is a normal pattern which is seen in babies. It should not be taken as the abnormal. So we should comment this background as a continuous background with we are seeing the spindle waveform. That means sleep-wake cycling, and we do not see any seizures in this amplitude integrated EEG recording, which displays 3 hours of recording on the conventional EEG. So here you can see the upper amplitude. Why we say this as continuous? The upper amplitude, upper margin is more than 10. The lower margin is more than 5 in all the places. So here this is the 5. So in all the places it is more than 5 only. The upper margin is always more than 10. So this is a continuous normal background with the sleep-wake cycling. So this baby has a normal cerebral function. So coming to the EEG changes with the increasing gestation. So when the babies are at a lower gestation, born at less than 25 weeks of gestation, the EEG is predominantly discontinuous with brief periods of continuous activity. So this is the conventional EEG. As the baby matures, so the continuous activity becomes longer and more frequent, and by around 35 weeks onwards, it is almost equal and same as that of the term infant EEG. From 32 weeks onwards, we can see the sleep-wake pattern and continuous EEG pattern becomes more continuous. At the younger ages of gestation, there will be lot of interburst intervals also, which around 26 by 21 to 22 weeks of gestation, and then it keeps on decreasing. And the pattern is becoming more continuous by the time the baby becomes around 34 to 35 weeks of gestation. So whenever we are seeing a EEG, AEEG, we will be seeing the type of background activity in terms of continuous or discontinuous, we will be seeing any interburst intervals and also the burst rates and cyclical variation with the different movements of the baby and the presence of seizure patterns. These are the four common things which we generally see in any EEG. So then coming to the trace alternance, which is a normal pattern which is seen um, in term babies. So the broader bandwidth here represents the discontinuous background activity which occurs during quiet sleep, and narrow bandwidth occurs during the continuous activity which occurs during the wakefulness and active sleep of the baby. So if we observe, there is a active sleep and quiet sleep for all of us, even for babies also. So that leads to the difference in the bandwidth, which should not be taken as abnormal as long as the lower margin is above the 5 only and upper border is above 10. So this pattern, sometimes appearing as discontinuous during quiet sleep of the baby, is called as the trace alternance pattern in the term infants. So now let us move on to the abnormal EEG patterns. This is the discontinuous pattern in which if you can see, the minimum amplitude will be less than 5 and the maximum amplitude might be more than 10 also. So if the minimum amplitude is going below 5, then we should call it as the discontinuous pattern. And we should see for the variability of the lower margin as well. So then we will go to the burst suppression. Here you can see it is lot of spiking is there, and that is immediately coming down, and then again there is lot of spiking. So that is called as burst suppression pattern. So here in the burst suppression pattern, the lower margin will be less than 5. This we should note. If the lower margin is always above 5, then we can consider it as a normal. If that is going below 5, then it should be discontinuous. And burst suppression, why we say? Because you can see the upper margin is always going uh, up to 100 also, and then it is immediately coming down, but not returning up to completely low. It is coming up to 10, and then there you can see the lot of bursts depending on the number of bursts that occur. So we divided this as burst suppression plus and burst suppression minus. And we don't see any variability of the lower margin, which we saw in the normal EEG pattern of the sleep-wake cycling. So the variability was there. Here we see it almost continuous and below 5. So if these bursts are more than 100 bursts per hour, then it is called burst suppression plus. And if the bursts are less than 100 per hour, so that means the cerebral activity is becoming even lesser. So this is burst suppression minus pattern. So burst suppression, discontinuous pattern, these are all abnormal. Now let us go to the continuous low voltage type of pattern, which we see in babies having encephalopathy, secondary to hypoxic ischemia or other causes. So in this, the minimum amplitude will, as already we discussed, will be always less than 5. And the upper amplitude margin is also always less than 10 when compared to the burst suppression, where it is going high and then dropping. So the burst will not be seen in the continuous low voltage. This is also an abnormal pattern in the EEG. And then the inactive or flat tracing. So in which we can see almost all the patterns which is less than 5 microvolts only. And we can see very minimal brain activity. Occasionally there are some spikes here and there, but overall the pattern is always less than 5 microvolts only. This is inactive or flat tracing, which is also very abnormal and indicates that the cerebral functioning is very less. So how this EEG will detect the cerebral function? So there will be like always electrical activity happening between the superficial part of the brain and the deep nuclei of the brain, between the thalamus and the cortical areas basically. This difference in the electrical activity between the gray matter and the white matter, between the thalamus and the cortical areas, is detected by the EEG and it is recorded on the graph. This thalamocortical connections will keep developing as the baby's gestation increases, and so that is how the EEG will be recorded per se. So if we see this kind of a graph, we can see that the electrical activity of the brain is very minimal. Means the baby is completely encephalopathic. Then how to identify the seizures. So after identifying the pattern, whether it is a continuous pattern or a discontinuous pattern, here we can see this as a discontinuous pattern where the minimal amplitude is always less than 5 in most of the areas. And here there is a sudden spike in the increase in the lower amplitude, which is going high up to 25 microvolts, and then it is dropping. So this can be considered as one episode of the seizure. So we should identify whether it is a single seizure or repetitive seizure or status epilepticus, in which we see the sawtooth pattern. Here we are seeing an abrupt rise in the minimum amplitude and a simultaneous increase in the maximum amplitude also, which is often followed by a decrease in the amplitude, and it might go to a low amplitude also. So in this 3 hours of amplitude integrated EEG, normal conventional EEG with 6 seconds of aEEG from the baby with discontinuous activity, and we detected one seizure in this whole graph at around 10 minutes of recording. So that is how we interpret this as a seizure. Then how will be the status epilepticus? Here you can see the sawtooth pattern on the EEG. I will just show you on this graph. So there is lot of variability and the amplitude is keep on increasing and decreasing, and which leads to the sawtooth appearance. This is the continuous seizure activity for this baby. Okay, so in an infant with this was an infant with severe hypoxic ischemic encephalopathy, depressed at birth, receiving extensive resuscitation after birth, and then seizure activity was noted, where you can see a continuous sawtooth pattern corresponding to status epilepticus. So here it is difficult to identify the background, whether it is continuous or discontinuous, as compared to the previous slide where there was only one seizure and there wasn't a discontinuous activity, because there is no full recovery between the two episodes of the seizures. So this is the second graph on this is the effect on with medication. Here the baby received the phenobarbital. So then we can see that the sawtooth pattern has ceased over here, and then it became into the burst suppression pattern from here. So the lower border is below 5 microvolts, and then there are lot of bursts. It looks like a BS minus, looks like there are less than 100 bursts per hour. And the recurrence of ictal discharges we can see at the end of this panel, where after the effect of the medication is being slightly weaned off, the baby again started throwing the seizures. So this EEG monitoring has become like mandatory to diagnose the seizures and then look for the effect of medications on the baby rather than just treating the baby clinically. So here we can also see the drift of the baseline after giving the phenobarbital. It is coming low and becoming more discontinuous with burst suppression pattern. So now we have seen the abnormal patterns on the EEG. So if we see the burst suppression pattern prolonged more than 20-second interburst interval, marked voltage suppression like we have seen the continuous low voltage EEG, and the flat tracing. These are the severe abnormalities in the EEG, and they help to guide us to decide about the prognostic value for the baby. Suppose how to predict the seizures, what is the prediction rate of seizures with EEG, we should know that. So in non-status epilepticus seizures, the EEG has a 76% accuracy versus conventional EEG to detect the seizures, because as we discussed, some brief small volume seizures may not be detected with aEEG because of this amplification, time compression, filtration when compared to the conventional EEG, and because of looking only at the few lobes of the brain as compared to conventional EEG, where 12 leads will be applied and all the areas of the brain will be covered, and the effect of artifact should also be taken care in amplitude integrated EEG. But roughly, in neonates with high risk of seizures, approximately 7 to 8 out of 10 seizures will be detected using the amplitude integrated EEG. Once we detect anything, the same should be confirmed with the conventional EEG, because doing a conventional EEG is a little bit more technically difficult and needs a lot of technician, equipment, and all those supports when compared to the amplitude integrated EEG, which is a bedside procedure. Short periods of seizure discharges can be missed in aEEG. So that is the reason which has 76% accuracy when compared to the conventional EEG, which is a good number. So now there are some controversies around aEEG. So when we are initiating therapeutic hypothermia for asphyxiated babies, we don't wait until the EEG is done and the um, electrographic seizures are documented, because a normal amplitude integrated EEG at 6 hours of life has a good negative predictive value, although it does not exclude adverse outcomes in the future. So clinically, if you feel the like you have done the scores for initiating the therapeutic hypothermia, I have seen the baby is depressed, having clinical seizures with the cord blood gas less than. So based on those criteria, NICHD criteria only, we should decide to initiate the therapeutic hypothermia of the babies rather than waiting for the amplitude integrated EEG. A normal EEG has a good negative predictive value, but it does not predict the long-term outcome. So we should not miss upon the window period of those 6 hours to initiate the therapeutic hypothermia. So this is one pitfall for the amplitude integrated EEG. And there is one more question, like does routine aEEG monitoring result in increased use of anticonvulsants? There have been many studies to look into this. They found out that there is not much increased use of anticonvulsants because of routine EEG monitoring in the units. So these are the two controversies which surround the amplitude integrated EEG. And what about the prognostic value of aEEG? With the help of aEEG, how do we prognosticate the babies with perinatal asphyxia, in other words? So the positive predictive value of unfavorable outcome if severe abnormalities, the ones which we discussed, are detected at 3 hours of life is around 78%, and at 6 hours it was 86%. If these severe traces are detected at 6 hours, then the positive predictive value is roughly around 86% with the help of the aEEG. So this is according to this journal of perinatology, where the study was done after a baby was with HI was put on therapeutic hypothermia for neuroprotection. A persistently severely abnormal EEG background at 48 hours of age or beyond predicts adverse outcomes with a positive predictive value of around 85%. And time to return to normal trace was the best predictor of good outcome or poor outcome in with a sensitivity of 96.2% in pooled babies and 90.9% in babies who do not receive the therapeutic hypothermia. And if the sleep wake cycle is not returning by at least 96 hours of life, then it always predicts the poor outcome in the babies, which we have to correlate clinically also. And then with the aEEG also, and discuss the prognostic value with the parents. So, prognostic value of aEEG in neonates following any encephalopathy. So, the neonatal encephalopathy occurs secondary to a number of constellation of findings, which can be either hypoxic ischemia or bilirubin-induced encephalopathy or hypoglycemia-induced encephalopathy or secondary to intracranial bleed or brain infection, meningoencephalitis, and epileptic encephalopathies, or different congenital and metabolic disorders and structural anomalies. Any of them can present with neonatal encephalopathy. This encephalopathy manifests in babies as decreased spontaneous respiration, altered mental status, changes in the tone, and depressed primitive reflexes, along with the seizures. So, a severely abnormal aEEG at 6 hours of life in a baby with neonatal encephalopathy predicts adverse neurological outcome with a sensitivity of around 70%, specificity of 87%, and positive predictive value of 75.6, and negative predictive value of 83%. So the aEEG is a tool which will help to assist in the along with the clinical diagnosis of the baby. So first the clinical examination and using the different scores like Sarnath and Sarnath score, Thompson score. These are very important. The aEEG is a tool which will help in predicting the prognostic value along with the clinical features of the baby. So there are some pitfalls or caveats for amplitude integrated EEG also. As I have mentioned earlier, the aEEG is very sensitive to interference from various artifact sources, which include surrounding electronic equipment, which will always be there in a baby with neonatal encephalopathy. Baby is on multiple supports like ventilatory support or invasive blood pressure recording, ECG leads, and the baby is having activities like spontaneous muscle movement, eye opening, respiration, baby on high frequency of ventilation, ECG leads. So these are the different artifacts which surround and interfere with the EEG readings. So that leads to the abnormal detection of the seizures if we are very naive and we don't know how to read the EEG graph. So in those conditions, it is always better to monitor the chart, the activity or procedures which are done at the time so that we can differentiate it from the artifact or the original seizures. And the staff taking care of the baby should be instructed to look for a loose electrode so as to keep the impedance at always less than 10. And frequent recording of the notes in the appropriate care charts for the baby and medication timings also should be noted down to facilitate the later interpretation of the aEEG. And we should not take care not to apply the needle electrodes above the fontanelles or sutures or any cephal hematomas. So that may lead to further worsening of the baby's condition and misinterpretation of the EEG. And if any local abnormalities are there in the skull, there also we should try to avoid placing the needle electrodes. And the electrode should not be placed in direct contact with the bedding of the baby. And as we discussed, the hydrogel electrode should be placed at the appropriate position on the scalp where there is minimal hair with the complete occlusion preventing the air entry. So after reading the patterns and then the seizures, effect of medication and concluding the findings on the aEEG, it is always better to correlate with one full conventional aEEG before discussing the prognostication with the parents. As we have seen in both the hypoxic ischemic encephalopathy and various other causes of encephalopathy, the positive predictive value is coming at around 80% for abnormal EEG, and return to the sleep-wake cycling, return to the normal pattern always predicts the good outcome. So we should continuously record the aEEG and look for the same pattern so that we can counsel the parents properly. And sleep-wake cycling, trace alternance, all these background patterns, normal and abnormal patterns, we should always keep in mind and look for them, and early return to the normal and effect of medications also should be observed time to time. And continuous aEEG is always a useful tool in addition to the clinical acumen of the physician, treating physician, to help in the proper outcome of the babies. So now I'll show this artifact on the amplitude integrated EEG, secondary to handling this EEG graph. So otherwise you see that it is a continuous pattern of the EEG where the low voltage is always above the 5 microvolts amplitude. And there is the spindling of the activity also. It is not at all discontinuous. But here you can see there is a brief elevation in the amplitude of the lower border, which is going up and then again coming down, but there is no depression in the overall amplitude, as we have seen in the previous graph with seizure, where there is a depression subsequently following seizure with the overall amplitude. So here, secondary to handling, you can see a transient increase only in the minimum amplitude of the aEEG. And when compared to the conventional EEG, we cannot see any ictal discharges in the original EEG. So that's why comparing both and noting down the caregiving procedures and baby movements is very important to interpret to the EEG and to avoid misinterpreting this as a seizure activity. So this is one of the commonly missed things, the artifacts which should be kept in mind whenever we are interpreting an EEG. So take the help of the neurologist also. Like once you have done your interpretation from your side, please take their opinion also, and then counsel about the prognosis and the other parameters to the parents. So that is about the today's class. If you have any doubts, you can type in the chat box. I will try to answer them. You can just send me a message also if you remember to have any doubts later on. I'll try to answer them and reply to them or you can type in the chat of this YouTube video also. You can enter your comments if you like this video. Thank you for your patient hearing.